Cancer Reach. Cancer Reach is an initiative by our very own tumor tamer, Dr. Krishnamani, to spread awareness about cancer and help patients and caregivers to access the right treatment at the right time. Today, we're discussing von Hippel-Lindau syndrome or VHL, which is a rare genetic condition that many people may never have heard of, yet it can affect multiple organs in the body. Through this session, we aim to simplify what VHL is, why it happens, how it shows up in the body, and what modern medicine can do to manage it. Our goal is awareness so that early recognition, timely treatment, and better outcomes become possible. Joining us today is Dr. Krishnamani, one of the most respected voices in oncology. He has been associated with AY hospitals here in Hyderabad for more than a decade, where he is known for his expertise in managing solid tumors, blood cancers, and oncological emergencies. His journey spans international fellowships and leadership roles at some of India's top cancer centers, giving him a truly global perspective on cancer care. He's also contributed immensely to the field, from shaping treatment protocols to influencing cancer care policies and driving research that really makes a difference. But what really stands out about him is his compassionate and patient centered approach. We're truly honored to have you with us today, sir.
Hello, everyone. Welcome to Cancer Reach. Cancer Reach is an initiative to spread awareness on cancer. And today, let's talk about VHL syndrome or von Hippel-Lindau syndrome, which is a not so commonly spoken or discussed topic, even in medical school or academic circles. It's just that we read a bit about it for our MCQs and all that. So let's discuss, let's read, let's know a little bit about it.
So, can you explain what is this VHL syndrome?
So VHL syndrome is what do you say? It's a constellation of symptoms, or it's a disease which affects a particular gene, which is called the VHL gene, which is present on chromosome number 3. So when you have a mutation in the VHL gene on chromosome number 3, those patients develop something called a VHL syndrome or a von Hippel-Lindau syndrome. So the VHL gene is basically a tumor suppressor. So that is in the cell cycle, there is a production and there is a degradation of cells happening. And that balance is what nature maintains. So now when the tumor suppressor gene or VHL gene, what it does is it prevents an overgrowth. So because of this gene, because this is a tumor suppressor by nature, it prevents an overgrowth, so the balance is maintained. Now, this gene is not there or it is mutated, the breaks are removed, so there is an overgrowth which forms cysts or tumors. So there is a constellation of symptoms, right from the brain to the eye, ear, spinal cord, your pancreas, kidney, nerves in your body, all these areas can be affected. Based on that, you call it as you categorize all those areas of involvement with VHL syndrome.
So, when you say it is a genetic disorder or a genetic syndrome, does it mean that it is present in a patient from birth itself and then it shows the true colors like after a
Correct.
few years?
Correct. So it is a genetic problem. It is because of the mutation in the tumor suppressor gene, which is called VHL gene, and it presents early in life, okay, or in adolescence, or late adulthood also sometimes. So it is present from birth. If you can ask me the mutation, uh, chromosome number 3, as I told you, which is a tumor suppressor.
Sir, how rare is this disease? Like, what would be the epidemiology of this disease?
So when I was reading up for today's interview, for today's talk, so the data which throws up is it is seen in 1 in 36,000 patients.
Okay, sir.
Yeah.
And sir, any particular gender which is affected by it?
No, male-female ratios are more or less the same.
Sir, can you explain how this one genetic mutation can lead to tumor formation in the body?
So as I told you, the breaks are removed, so there is an overgrowth of the cells, which leads to cyst or tumor formation. So you can present with uh, tumors which are called hemangioblastomas in the eye, in the brain, in the part called cerebellum. You can present with cysts in your ear, middle ear cysts, endolymphatic sac tumors. You can present with cysts in the pancreas or neuroendocrine tumors or renal cysts, cancers, renal cell carcinoma, or an adrenal tumor which is called a pheochromocytoma. So all these things can be part of a VHL syndrome.
Sir, what could be some of the major symptoms to identify this at an early stage?
So one of the earliest symptoms which is generally seen is patients present with vision issues. So that is one of the earliest symptoms you present. If you have a cerebellar hemangioblastoma, you can present with ataxia or swaying to this side or that side or slurring of speech. Sometimes they may have weakness of the limbs. If they have a spinal cord hemangioblastomas, they can present with bowel or bladder incontinence. That could be one symptom. They can present on incidental imaging a mass in the kidney. They can present with blood pressure fluctuations because of pheochromocytoma or heart rate fluctuations. So any of these can be there.
So, sir, these masses or these cysts, they can be both benign and they can be malignant.
So cysts are usually benign, but you can also have malignant tumors in the form of RCCs, renal cell carcinomas, or pheochromocytomas, or neuroendocrine tumors.
Sir, how do you diagnose these tumors or the cysts?
So somebody may present with an eye issue. You do a detailed examination, you look at hemangio. So if you look at a retinal hemangioblastoma, I think the first thing you should start suspecting is whether the patient has VHL and start screening the patient. How do you screen the patient? You'll do an eye exam, you will do dilate the eye and see, you'll do a brain MRI or a brain, preferably a brain MRI. You'll do a spinal cord MRI, ultrasound of the abdomen or a CT chest, CT abdomen to look for pancreatic masses, to look for kidney masses, to look for neuroendocrine tumors. So this is the way you're going to evaluate the patient.
Sir, if one family member is affected with the VHL syndrome, what are the chances that the offsprings would also be affected with the same syndrome?
So if one of the parent is affected, there is a 50% chance that the child could be affected. This is called an autosomal dominant kind of a penetration. So if one parent is affected, there's a 50% chance that 50% chance that a child could be affected. And all the kids are obviously going to be screened for the VHL mutation.
Sir, any specific genetic mutation testing that you do for the syndrome?
You do a proper sequencing and you check for the mutation on chromosome 3. And if it is present, then they are called a VHL carrier. And if they are VHL carrier, even if they are asymptomatic, you have to there is a screening methodology and that has to be followed.
Sir, once the patient is diagnosed with the syndrome, is the patient immediately started on treatment or what protocol do you follow?
So now you are not, if somebody may be asymptomatic, so you can have different sets of scenarios, right? Somebody can just present as an eye issue. Somebody can present with just a brain issue. Somebody can present with multiple tumors in the eye, brain, the spinal cord, here and there, everywhere. So it depends on what is the kind of presentation they have. If somebody just has an eye problem, you're going to give a laser therapy or a phototherapy or a proper ophthalmologic consult, and you're going to cure that eye issue or temporarily control it. When regards to the brain, stereotactic radiosurgery is extremely useful. In the spinal cord, if there are small tumors less than 2 centimeters, no pain, no back pain, no urinary bowel bladder incontinence, you are going to leave it alone and do a frequent MRI once in one every 2 years or once a year. If it is growing, then you will intervene. Otherwise, you can keep quiet. Kidney tumors or pancreatic tumors less than 2 or 3 centimeters, you're not going to touch. Only if they are above 3 centimeters, generally the dictum is you go for surgery for those patients. So if somebody is asymptomatic, small volume of disease, you're going to keep them under regular follow-up with the yearly MRI. MRIs are preferable than CT scans because you doing it yearly means frequently. MRI doesn't have radiation exposure. If you do a CT every year, then there's a lot of radiation exposure. But on the contrary, if somebody is symptomatic, a tumor which is more than 3 centimeters, which can be surgically removed and the patient is fit for surgery, then you would probably go that line.
Sir, does chemotherapy or targeted therapy play a role in these situations?
So recently, there is a drug called bezeltifan, which has been approved, which is called a HIF alpha inhibiting factor. So hypoxic inhibiting factor, So it inhibits that. So it shrinks the tumor. So Basaltifan now is approved for those patients who have these tumors, where you want to shrink the tumors, and those patients are not yet candidates for surgery. That is, they are small, they are not surgical candidates, but you can shrink those tumors so that you can postpone the surgery. So that is the advantage of Basaltifan. So it's an oral medication. So that is the only drug which has been approved for VHL. So it is approved in those patients who have renal cell carcinoma, who have FIOS, and who are not for surgery yet.
Sir, is it like if the patient is operated, then the patient would not require any further treatment, or like the
Yes,
disease is in complete remission?
correct. They will be on regular follow-up with
Okay.
surveillance MRIs or surveillance scans.
Sir, what about the recurrence of the disease? Is it possible in these patients?
The recurrence is so there is a chance that the disease would recur at any point in time, predominantly in other areas. So it is not that you have a brain one and you're not going to get in the spinal cord tomorrow. So this person is at a chance of uh, developing at multiple places. So that is precisely the reason. So that is precisely the reason you're going to keep them under surveillance.
Sir, what about the prognosis of this condition?
So the prognosis varies. The prognosis varies. So purely from a standpoint whether a patient is symptomatic or not. If somebody is symptomatic, especially with spinal cord tumors, then they are going to develop weakness and those kind of issues. Otherwise, you're going to have many patients who are going to be long term on follow up. And with Basaltifan, if you look at the data also, there is a 5-year data. The drug has very good response rates, very good shrinking of the tumor. And prior to Basaltifan in that study, 86 surgeries were required, and post Basaltifan, only 18 surgeries were required. So, what that promising data shows is you have drugs where so some patients they may need surgeries at different places at multiple time points. This probably is a drug which prevents those patients from needing multiple surgeries.
Sir, when we talk about the quality of life of these patients, how would you describe it?
So we have a few patients who are on follow-up. There is the quality of life again depends on where you have the tumor, how well it has been treated, what is the size of the tumor, etc. But generally, it is good if they are small volume tumors, small amount of disease, smaller size of tumors. More importantly, but they always have a scare that I may develop a kidney cancer tomorrow. I may develop a neuroendocrine tumor. I pheochromocytoma, etc. Or I have to be under constant surveillance. So that is something which becomes part of their routine. So we have to tell them that, see, it is not a one-off MRI you have done. You have to constantly get yourself screened every 1 year, every 2 years. And the screening starts as early as 1 or 2 years to check the eye for a baby. At the age of 5 or so for the brain, and for the kidney and the pancreas, your screening starts as early as the age of 10 or 11 years. But maybe you can take an individualized decision in some patients who, for prolonged periods, suppose for 5, 8 years, the tumors or the cysts are the same size, they are not increasing in size, the patient is asymptomatic, then you can probably say, see, you have done well for 5, 10 years now. I will not do yearly MRIs. I'll do probably once in 2 years MRIs, once in 3 years MRIs. You can increase the frequency of the scans.
So, what advice would you give to patients and families on living well with VHL and for planning for the future?
So what you should understand is you have a chance of cysts or tumors in different locations. Know your symptoms. Any abnormal symptom, please take a consult immediately. Start your screening early. All those patients who have VHL, please screen your family members for VHL. And if they are carriers, start screening yourself as early as possible. And finally, if you have the disease, watch out for your symptoms, be under surveillance. If you have symptoms which need surgery, surgery is the way to go if the tumors are more than 3 centimeters or so. Or now you have basaltifan, which helps to shrink patients having tumors who are not going to go for surgery.
So, can you summarize today's session?
So to summarize is what we said, you can have a myriad of symptoms right from the eye to the brain to the cord to the kidney to the adrenal gland. Uh, the symptoms can be very, very simple like an eye issue or basic ataxia or blood pressure fluctuations, etc. Watch out for these symptoms, especially if anybody in your family has this disease, then screen yourself for that. And if you're a carrier, start screening early. And MRIs are preferred compared to CTs purely because they have no radiation exposure.
Sir, can you tell us about the second opinion campaign being run by you?
So we are having this second opinion campaign on WhatsApp where patients can put up their reports, and we will try to reply them as early as possible with the best possible advice we can give them based on the reports they send to us.
Thank you for today's informative session, sir, and we hope to see you again next Friday with another informative topic. Thank you, sir. Thank you
Right.
for your time.
Thank you so much.